For newborn screening, as I said, it's a state program, and each state is different, and each state newborn screening program is different, and each state has their own constitution. So having to work individually with each state, you can't go in with a piece of paper and be like, pass this. So we go in with a set of ideas, and we work with each state to figure out what works best for them. And so it starts off with that the state will screen for all conditions on the RUSP. And so currently the RUSP is the goal. If a state has reached there's currently 35 conditions on the RUSP. If they've reached all 35, they're thrilled. They have done what they're supposed to do. And in our opinion, the RUSP should be the minimum. That's where the starting point should be. And so that's the first idea, that auto inclusion of all RUSP conditions. The second part is a timeline. And so ensuring the fact that they will screen for conditions within a certain amount of time that it's been added to the RUSP. So currently it takes on average 5 to 6 years to add a condition once it's then been added to the RUSP at the state level. And so the issue with that is that it can take 5, 10, 15 years to add a condition to the RUSP, because it is a very evidence-driven process, and a lot of time, a lot of effort goes into developing that package. And once you have that package and patient advocacy organizations have been putting in all this time, well, now they have to go around the country and try to pass it again, and it takes too long. And so it varies state by state. It's typically between 2 to 3 years that the RUSP alignment legislation. Georgia is actually 2.5 years. But it puts a real deadline that you have to screen by this date. We understand that things need to be done. There's a reason that it's not 6 months, that we are giving 2 years. You do have to buy new machines. You do have to potentially buy or hire new staff. You have to make sure the machines are working. And we appreciate the fact that there is work for state labs to do to ensure they can add a condition properly. But we also appreciate the fact that 6 years to add a condition is too long. And those are lives lost. Those are currently, there are 4 conditions that have been added. They're the most common that have not added, which is MPS 1, SMA, Pompe disease, and ALD. And for every 100,000, those are 22 newborns will be identified for those 4 conditions. And so for every state that doesn't screen for all 4, those are 22 newborns who are, on average, who are not being identified. And so while we can appreciate that there are administrative reasons to take the 2 to 3 years, any extra time, I mean, those are lives. I mean, at the end of the day, newborn screening saves lives, and ensuring that we have a timeline saves lives. And the last part of it is ensuring a funding source. So if we're going to require them to screen for all these conditions, and we're going to require them to do it in a certain amount of time, it's only fair to ensure that they have the money to do all that. And so, and this is a part that really varies state by state, because again, we're going into the constitution, the state constitution, of whether or not a health commissioner can automatically raise a newborn screening fee. Do you have to go through the state assembly? So that's where it varies a lot. And that's where we really want to work with the state labs and the state newborn screening programs with them to identify what does work best for them. This is, as I said, we don't go in with a piece of paper and say, pass this. We go in and we want to work with the state program and the state lab to figure out what works best for them within our mold of what RUSP alignment legislation should be. And so it's really, how do we make sure that we get the money that you need in a timely fashion to buy that machine, to buy the extra staff, to ensure the follow-up program is working the way it needs to. And so that kind of, those 3 aspects are what support the newborn screening legislation.
So in Florida, we did appropriate a specific amount of money for one of the diseases as a I think it was ALD, but basically when we went in there right away, they're like, we're not passing this because the governor line item vetoed our budget to do this disease, so we're not going to pass your legislation. So we went in there and we passed their budget request for that disease. But they typically know, the state labs typically know how much it costs to implement a new disease. They have a number from whatever it was to implement the last one. So, but we don't put that necessarily line item in the appropriation unless it's a political strategy that we need to do. So what we, like in California, there's language that says something around, I don't remember what it was. All the bills are only like 10 words. Like we really try to have very few words. But I can't remember exactly California, but it was basically like to make the appropriation happen, right? Like it basically requires the state to ask for the money.
And that's similar to the language we have in Georgia. Is essentially it requires that the money that is needed is included in the state budget request coming out of the Department of Health. And so, because to answer your question, however much it's going to cost is going to vary based on the disease, because that's going to depend on what machines you need to buy and do you need to hire new people, like all of that. Do you need to get a new building because you have run out of room with your machines? Like all of this is going to definitely be very much condition by condition, which is why we don't want to put in a hard, okay, this is how much we put in. And so we want to give the labs the leeway to be like, okay, here's how much it costs. And so for Georgia, it has, there's an 18-month period where you have to put the budget in. And once it's appropriate, you have then 18 months to then start screening for the condition. So essentially it's like they're required to ask for the money. Once they receive the money, they then have 18 months to spend the money to ensure that they can actually begin screening for the condition. And so it's a recognition that how much it costs to screen for SMA in Georgia will be different than California, than Montana. And not because SMA is different in those states, but because those state programs are run differently. And how they run it will vary slightly. And obviously, populations vary immensely between those states. And so however much it costs for each condition is going to vary, but we want to empower the lab to get the money that they need to screen for these conditions.